Welcome to this version of Fertility 101. Tonight we are going to have a special focus on PCOS, but the majority of this is just going to be the basics, kind of introduction to fertility. So I am your host this evening, Dr. Ilana Ressler. I'm a board-certified reproductive endocrinologist, which means I did a residency in OBGYN for 4 years and then a subspecialty fellowship in reproductive endocrinology and infertility. And actually, during that fellowship, half of the time was spent doing basic science research in the area of PCOS. So that is a topic held near and dear to my heart. So who else is in this practice? Well, there are actually 9 of us who are board certified reproductive endocrinologists. We have 5 locations, including 4 in Connecticut, Norwalk, Stamford, Danbury, and Trumbull. Our main headquarters and IVF lab is in Norwalk. And then we also have an office in Westchester, in Harrison. We have an on-site surgical suite. Again, that is in our Norwalk location. We also have laboratories in all of our different locations for andrology, for the processing of sperm. And then our IVF lab is in the Norwalk location. We have many certifications, including a special program actually called the Integrated Fertility Wellness Program, which I'm going to be talking a little bit more this evening. So let's get started in terms of what we can offer from our practice. We can do fertility evaluations, which I like to call reproductive checkups. We can freeze eggs or sperm or embryos for those who aren't ready to start their family building yet, but may know that they want to in the future. For those who are ready to begin their family building journey, we offer both IUI, intrauterine insemination, as well as IVF, in vitro fertilization. We offer donor conception, meaning using donor sperm or donor egg, as well as gestational carriers. In addition to the traditional medical practice, we believe in looking at the whole picture. So we offer holistic support in the ways of acupuncture, counseling, nutrition, and various support groups. So let's get started with the Fertility 101 part. So what is infertility? How is it defined? Well, it's defined by not being able to achieve a pregnancy after 1 year of trying, or for those who aren't able to try, perhaps because they need to use donor sperm, that also qualifies. They don't have to be, trying for a year without success. There are some basic building blocks that we need to make a baby, right? So that involves the egg, the sperm, and the uterus. And there are different ways of using these different parts, but those are obviously the basic building blocks that we need. So we're going to take a minute to talk about and look more closely at these different parts. So in terms of female anatomy, this is just a basic model of female anatomy. So we have the vagina, the cervix, which is the entry into the uterus. These are the fallopian tubes and the ovaries. So it's inside of the ovaries where the eggs are stored. We can't see the eggs, they're microscopic, but they live in the ovaries. So we're going to talk next about what happens in a natural cycle. So on average, a cycle is about 28 days long. The normal range, though, can be between 21 and 35 days. So this represents what's happening, this middle row here in the ovary. These represent different hormones, and the bottom is what's happening in the uterus. So at the start of a cycle, or with the onset of a period, basically there's this whole group of eggs, which are contained within the follicle structures, right? So there's this whole group of follicles waiting for use. And then there are hormones that talk between 2 places in our brain. They talk down to the ovary, it feeds back, and that's what carefully regulates the cycle. So in particular, there's this hormone called FSH, follicle stimulating hormone, that sends the signal, and one of the follicles will grow bigger than the rest. That is called the dominant follicle. So it typically takes about 2 weeks for that follicle to develop and the egg to mature. And then mid-cycle, there's the LH surge, which is another signal from the brain telling the follicle, okay, it's time to ovulate, release the egg. This growing follicle has been making estrogen, and then after ovulation occurs, that site in the ovary becomes what's called the corpus luteum, and progesterone is made from that site. If no pregnancy is achieved, these hormone levels fall, and then it starts all over again. The lining sheds, and we're back at square one. So I think it's really important. I review with all of my new patients this exact diagram and these ideas, because everything we do, all of our treatments, even the testing, like everything is based around this cycle. And really, when we're doing any sort of treatment, it's just like a manipulation of what's happening in the natural cycle. So let's focus on each of these different components now. So in terms of the eggs, there are two things that we consider when we're thinking about the egg health. It's both the quality and the quantity. Okay, so there is really no measure for quality. It's just very closely associated with age. So the highest quality eggs being under the age of 35, and slowly that starts to shift as we get older, especially as we cross into our mid 30s and beyond. However, the egg quantity can be measured. There are actually three different markers that reflect the ovarian reserve. So one is a hormone called AMH, anti-Mullerian hormone. This is a hormone made by cells that surround the eggs. So the more eggs someone has, the higher her AMH, and that goes down as we get older. It doesn't vary throughout a cycle, so it can be drawn at any time. It can also be drawn even if someone is on a birth control pill. That level might be slightly suppressed when on a birth control pill, but it still gives a pretty accurate reflection. The second hormone, however, the day 3 FSH, this cannot be drawn while on a birth control pill, and it must be drawn, as the name implies, day 3 at the start of a cycle. And this is because FSH, as we saw in that prior diagram, does fluctuate throughout a cycle, and it should be low at the beginning. So that's when we need to draw it. So there's always some wiggle room. It can be days like 2, 3, or 4. Day 1 is the first day of bleeding. Okay, so around day 3, we measure the FSH, and then that same day, we do an ultrasound, a transvaginal ultrasound. We look at the ovaries and we count the little follicles. So if you think of the ovary kind of looking like a chocolate chip cookie, and all the little chips are the follicles, these little black circles, and we count them, and that gives us the third measure. So we put these 3 measures together to really get a sense, does someone have like a low, average, or high reserve? We can't count exactly how many there are or know when someone will run out of them, which is when they go through menopause. But it gives us a sense, and this tells us not necessarily like a prediction of ability to conceive, but rather like how aggressive to be, how to dose medications, expectations of how someone might respond. Great. So if we find out that someone has like a lower than expected ovarian reserve and they haven't started their family building yet, we may suggest preserving fertility, like freezing eggs or embryos, because we know with time that's only going to continue to decline. But of course, quality is the most important, and whether someone has a lot or a little, that does go down with age. So what does that mean, quality? So the egg has DNA inside of it, right? And when it combines with the sperm, then the DNA has to divide evenly to have the proper number of chromosomes. And as eggs age, they don't divide evenly as much. So by the time we are in our, even 40, most eggs are no longer healthy. And by the time we're in our mid 40s, mid to upper 40s, essentially there's no more healthy eggs. So we might still have periods for several more years until menopause, but the chance of having a healthy baby with our own eggs at that point is really gone. So for those who are in that situation, we also do have services to offer with use of a donor egg, which is an egg from a young woman who is then whose eggs are then used to create the embryos, and the embryo transferred into the intended parent. So we actually are born with about 1 to 2 million eggs. We had the most before we were born. When we were in our mother's uterus, we had about 6 or 7 million. By the time we're in puberty, it's down to about 500,000. And they're just rapidly depleted throughout our life. That's how we go from having millions to none in about 50 years. And we haven't figured out how to stop that process. So whether someone has, is on a birth control pill or pregnant or whatever the situation, the eggs are continuously turning over. We can't like stop that process from happening. The only way, again, to preserve it is to take them out and freeze them. So again, by the time we hit menopause, no more eggs. That by definition is no periods for a year. And the average age in the US is 51 of that happening. So in terms of, again, predicting like success with fertility treatments, age is one of the biggest predictors. It doesn't mean that when someone hits 35, it's all like rapidly downhill from there, but things do slowly change over time. As I mentioned, once we're 40 and above, really the eggs are mostly not healthy anymore. So it becomes kind of a numbers game of finding those good ones among what's left. So moving beyond the eggs, there are other important components to conception, one being the fallopian tubes. So we have a test called a hysterosalpingogram or HSG, in which we are able to assess the fallopian tubes. So we place a little catheter inside of the uterus. We put a little bit of dye in there, and that dye, it fills into the uterus, fills into the tubes, and spills out of both ends, indicating they're both open and healthy. So we do this within our office. 3 of our office locations have the X-ray machine in it. It can be a little bit uncomfortable, this test, sometimes a lot uncomfortable for certain people. Some people feel very little, others feel more intense, like menstrual cramping. So we do recommend taking some ibuprofen about an hour before. But it is a very quick test, like less than a minute once the catheter is inserted. That HSG test tells us a little bit about the inside of the uterus, the uterine cavity, but it doesn't give us a lot of detail. So we do a separate test called a saline sonogram or water ultrasound or sonohystogram. There are a few different names for it, but essentially we again put a little catheter in the uterus, we put some saline inside, and we can then distend the walls of the uterus to see what is going on inside of the uterus. Is there, like in this image here, a nice big polyp that's occupying the majority of the cavity? So if we found this, we would certainly want to take it out, right? You can see this probably isn't actually so big. It's probably maybe a centimeter or 2, but the whole cavity is not that big. So even like a relatively small lesion like this can really have a big negative impact on fertility. So if we find even a much smaller polyp, our recommendation would then be to remove it, which we take care of in our office. In our surgery center in Norwalk, a patient will get a little bit of IV sedation, so she's asleep and comfortable, and then we just basically put a camera inside of the uterus where we can directly visualize what's inside, and we have instruments that can remove that tissue at that time. All right, so obviously it's half and half egg sperm. So we are interested, of course, in what the sperm health is. By the way, when we do fertility evaluations for those who have been experiencing infertility, about a third of the time we may find something related to the female, about a third of the time to the male, the other third, it could be a combination of the two, or about 20% of the time, the test results might all come back normal. This is something called unexplained infertility. It doesn't mean that there's not a problem, but we might just not have the right test to detect what it is, but we still do have specific treatment for those with unexplained infertility. So in terms of evaluating the sperm health, we do a test called a semen analysis. And essentially, there are 3 main parameters that we look at: the concentration, how many there are; the motility, how well are they moving; and the morphology, how many are normal in shape. So it's actually pretty interesting. Most sperm are abnormally shaped. So we just need a sample to have greater than 4% appearing normal for that to be considered a normal sample. So most sperm actually have some sort of defect with either their head, the neck or the tail piece. Because if you think about it, there's like millions and millions of sperm in the ejaculate, and most of the time it doesn't even fertilize a single egg. So there are some inefficiencies intentionally built into like reproductive health. So when we do an analysis, if it looks normal, great, we don't have to do anything further. If it's abnormal, we often like to repeat it because we don't know, was that like a good day, a bad day? We want a little bit more of a sense of an average. So again, I just mentioned, different causes related to male, female, but more specifically, there can be ovulation dysfunction in which a woman isn't ovulating on a regular basis, which can make it really hard to know how to time conception. There can be low quality or reserve of the eggs. An issue with the sperm malfactor, endometriosis is associated with subfertility. There can be issues with the fallopian tubes. If one or both are blocked, the egg and the sperm wouldn't meet on that side. There can be issues with the uterus, for example, the polyps, or if there are fibroids in the cavity. And again, there's that category of unexplained. There are also those who, for other reasons, may need assistance from us. For example, use of donor sperm for same-sex female couples or for same-sex male couples. They would need to use donor egg and a gestational carrier, or single women would use sperm donor. It's important not only to consider, though, all these medical pieces of it, but really, like I said, to look at the big picture and make sure one is as healthy as they can be in terms of like nutrition, exercise, and focus kind of on the bigger picture as well. Okay, so when it comes to the treatment, what sort of options are there? One option is called ovulation induction. This involves like a gentle stimulation of the ovaries. So not only one egg develops that cycle, but maybe two or three. And we track the growth of those eggs throughout a cycle, and we help time ovulation so someone knows when that is happening. We often combine this in addition to intercourse, if that's feasible, with an IUI, intrauterine insemination, where we put a sample of the sperm in the uterus closer to the egg at the right time. Then there's in vitro fertilization, where we stimulate the ovaries to make many follicles grow, take the eggs out, combine them with the sperm outside of the body, and then transfer one into the uterus. There are methods of preserving fertility, both egg and sperm freezing. There's donor conception, as I mentioned, use of donor egg or donor sperm, and there's use of a gestational carrier as well to use someone else's uterus. So we're going to just touch on some of these for a moment. So for egg freezing, this involves stimulating the ovaries. So essentially egg freezing and IVF are the same thing until the eggs come out. If someone is freezing the eggs, or doing egg freezing, then once the eggs come out, they're frozen without being combined with the sperm, which has to be done at a later time. If someone's doing IVF, again, it's the same process, but then upon a removal of the eggs, they're put together with the sperm to create the embryos. So we use hormonal medications, the same exact hormones I talked about at the beginning, the FSH, that's the main stimulation hormone that gets the follicles to grow. So those are taken by subcutaneous injection, so tiny needle just under the skin in the abdomen, on average for about 10 days or so before the eggs are ready to come out. The egg retrieval is done under IV sedation. So someone is asleep and comfortable, they don't feel anything. And we essentially use a needle through a transvaginal ultrasound probe to go through the vaginal wall into the ovary. And then we drain all of those follicles of the fluid, and somewhere floating in there is an egg. So we take the eggs out from each follicle. Then once they're removed, we use a process called vitrification, which is like a process that rapidly freezes the eggs. And this is very effective at freezing them. So ultimately when they thaw, more than 95% in our lab survived the thaw. Historically, there was an old method of freezing eggs, which is called slow freezing, and that was much worse. Many more didn't survive. So egg freezing was considered experimental up until about a decade or so ago, because that's when vitrification really had proved itself to be equally effective at freezing eggs as it was with freezing embryos and sperm, because eggs are more challenging. There's like a larger surface area and higher water content in them. So freezing used to be more challenging. In terms of storing them, they are stored in specialized tanks under very special conditions, special monitoring conditions, until ready for use. And that can be 1 year later, 5 years later, 10 years later. There's no like shelf life, so to speak, of how long they can stay frozen. But upon when they're ready for use, they then have to be thawed. And at that point, put together with the sperm to then create the embryo. And then an embryo can be transferred into the uterus. If there are additional embryos that are created, we would transfer typically one embryo at a time. Any other embryos can then be frozen again and used for future use as well. Intrauterine insemination. So as I mentioned, this is often combined with the ovulation induction. So first we, again, gently stimulate the ovaries typically to get a couple of follicles to grow. And then we time when ovulation occurs with a medication so we know exactly when it's happening. And then we perform the IUI typically around 36 hours after taking that medication when we know the ovulation process is going to start. So the sperm sample is washed, it's concentrated, it's placed in a syringe attached to a small catheter, and the catheter is placed into the uterus and the sample is left there. It's not painful. Someone can continue their regular activities that day, and about 2 weeks after that, we know the outcome of this cycle. It is used generally for those who have issues like mild malfactor, or even if the sperm parameters look healthy, it can often be useful because it does optimize things by putting the sperm closer to the eggs at the right time. Okay, so with IVF, this again is the same process I explained before in terms of the egg freezing. It's just the difference is once the eggs come out, they are combined with the sperm. So if the sperm parameters are normal, we let the eggs and sperm sit together in a dish and fertilize as they would naturally. But we can also use a technique, especially for those who do have malfactor, called ICSI, intracytoplasmic sperm injection, where we actually, this image is showing that, where we place the sperm and we like hand pick a normal looking sperm and inject it directly into the egg to maximize the chance of fertilization. This does involve taking daily hormones, as I mentioned. It is a higher cost generally than doing an IUI type of treatment, but it's also the most successful treatment we offer. So in sort of a best case scenario, an IUI type of treatment cycle is going to work up to about 20% per cycle. As women get above the age of 35, that will decline. As opposed to IVF, that's going to be more like 60 to 70% chance of success per embryo transfer. Again, for those who are under 35, or for those who actually do genetic testing on the embryos to show that they're chromosomally healthy, then it doesn't matter how old someone is, that chance of success goes back up to the highest. And again, we use either donor eggs, donor sperm, a gestational carrier. There are all different ways of family building. And so obviously for each individual patient, we come up with the best plan for them. So now I want to switch gears for the last few minutes of the presentation, just talking about the featured topic of the evening, which is PCOS. So how do we approach getting pregnant for someone with PCOS? It's essentially similar, right? You would schedule a consult to meet with someone like me, a reproductive endocrinologist. We would do all the usual fertility evaluation, but there would be some additional testing that we would do to look at some of the other issues that are associated with PCOS. For example, looking at some metabolic factors like glucose testing and things of that nature. And then just like anyone else, we would decide what is best, whether it's ovulation induction, IUI, IVF. And we would add in, though, extra support from, for example, working with one of our dietitians, because at the core of managing PCOS is really nutrition and exercise, which I will talk about in a moment. And in case you didn't already know, September is actually PCOS Awareness Month. So it is really a condition that has obviously been around for a very long time, but unfortunately hasn't really had the recognition that it merits. It is really a comprehensive condition. It doesn't only affect someone's fertility. It's actually much more, again, comprehensive than that. So again, September has been deemed PCOS Awareness Month. And just to add, of course, having PCOS does not mean you will not be able to achieve a pregnancy. Many women with PCOS achieve a pregnancy on their own without our help. But many do need our help, in particular because of the association with irregular cycles and PCOS, which means there's ovulation dysfunction, and it can be a little bit more challenging to time ovulation when the cycles are irregular. So let's just take a step back and talk about how we diagnose PCOS. We use the Rotterdam criteria. So essentially, someone has to have two of the following three things. One is having irregular cycles. So again, the normal range is 21 to 35 days from the start of one to the start of the next. So if it's falling outside of that range, it's considered irregular. The second part of it is having elevated androgens. So these are hormones like testosterone or DHEAS, or the levels might be totally normal, but there are symptoms that someone has driven by these, like acne or excess hair growth called hirsutism or hair thinning. So that would qualify as that second part, even if the blood work looks normal. The third is having polycystic appearing ovaries, which is a little bit confusing. I'm just going to jump over here to this slide, which it's called polycystic, but it really, in my opinion, should be called polyfollicular because that's what the polycystic ovary is referring to. It's referring to the number of follicles. So you know how I said we can count the follicles? It kind of looks like a chocolate chip cookie. So you can see here, there are many follicles in this ultrasound image. So if there's above a certain number of follicles, that is what makes it a polycystic appearing ovary. So just to go back for a second, so someone can have any two of the three. So someone might have actually not irregular cycles, but they have the polycystic appearing ovaries and elevated androgens, or they might have the ovulatory problems and the androgens, but not the polycystic ovaries. Or many people actually meet all three of the criteria, but again, you just have to meet two of the three. Okay, so just to this is just about the end of the discussion, but I just want to add in terms of PCOS and another comment about how it's really a comprehensive condition, right? It's like associated or categorized as a gynecologic or reproductive condition because of the ovulation dysfunction associated with it. But it is important to look at other aspects, whether someone's trying to conceive or not. For example, the metabolic association. So PCOS can be associated with things like insulin resistance, or which can lead to things like prediabetes or diabetes. So we recommend doing a 2-hour glucose tolerance test. It can be associated with higher cholesterol, with weight gain, difficulty losing weight, weight being carried more in the midsection. The androgens cause skin problems like acne or the excess hair growth. And anxiety and depression are actually also associated with PCOS. So when someone has PCOS, we really do, again, a more broad evaluation. And then, you know, obviously, if the goal or intent is to conceive, then that is what we would focus on for that individual. So when treating PCOS, we kind of, there's a little bit of like a decision tree. And one of the first, you know, questions that I want to know, is someone trying to conceive or not? Because if they are, then the focus of treatment is going to be very different than someone who is not. Okay, so in terms of next steps, we would love to see you and answer questions. I'm gonna actually look at the Q&A in a moment. So now is the time. If you have any questions, please enter them into the Q&A part, and I will do my best to answer them. And again, you can schedule a consult with any one of the 9 doctors in our group. And we do have this PCOS ebook, so please feel free to download it. Okay, perfect. So I'm just going to turn it over, look at the Q&A. Okay. So one of the questions is a someone is asking, they have PCOS and they've had a tubal ligation. Is it possible to get pregnant? So tubal ligation is when, the tubes are tied with the intent of not having more children, but obviously, someone can change their mind and still desire future fertility. So the answer is yes. It is possible to get pregnant in that situation, but IVF would be needed. So when we do IVF, we actually don't use the fallopian tubes, right? We bypass them. So we stimulate the ovaries, take the eggs out, combine them with the sperm, and put the embryo back into the uterus. So the job of the tube in nature is like the meeting place of the egg and the sperm. But with IVF, we are bypassing it. And that is, again, our most successful type of treatment. And having PCOS and doing IVF, in some ways is actually a benefit because the egg quantity is going to be very high generally for women with PCOS. Those polycystic appearing ovaries are loaded with the follicles, so they have the potential to actually stimulate very well and have many eggs in a retrieval to therefore create many embryos. Over time, of course, the quantity declines just like anyone else, but certainly conception is feasible in that way. Okay. Another question is someone is stating that she is BRCA positive. Is it possible to screen the eggs before freezing, or can it only be screened at the embryo stage? So this is a great question. I didn't really talk about genetic testing much in this talk this evening, but the short answer is it cannot be screened in an egg. It can be screened in an embryo. So we recommend in situations like that, if someone wants to screen the embryos for the BRCA gene, they would work with one of our genetic counselors, and actually a probe would be built specific to the mutation. So whether it's BRCA, or let's say there's a couple, both partners are carriers, let's say for cystic fibrosis, right? So before starting, like part of the initial evaluation that we do is actually doing genetic carrier screening. So looking at each partner to see if they are a carrier of one of these commonly inherited genetic diseases. And in some situations, we find that both partners are carriers for the same thing, which would mean they're at increased risk of having a child with that disease. So whether it's a situation like that, or whether someone has something like the BRCA gene, we can, again, build probes specific to that mutation and test the embryos to see in the BRCA situation whether it's there or not. So 50-50 chance, or with the carriers, like if both are carriers for cystic fibrosis, we would see if the embryo has 0, 1, or 2 copies. The ones with 2 copies would have the disease, and we can avoid transfer of those embryos. Okay, great question. And another question, basically asking about nutrition when trying to conceive. Is there like a particular diet or nutrition? So the general answer is to try to be as healthy as you can. I always say it's best to be your like healthiest self going into a pregnancy, because that will just promote having a healthy pregnancy. And at the end of the day, that's what we all want, is to have a healthy baby. So in terms of nutrition, generally a good balanced diet is what's recommended, kind of like a Mediterranean type diet with all the different food groups represented. It's not good to over restrict. We don't want to like eliminate all of one food group, like sugars, carbs, dairy, gluten, soy, et cetera. If someone has an intolerance to that, that's a different situation. But really, we want to represent all the different groups. We are really fortunate to have 2 amazing registered dietitians in our practice. They're available for anyone to meet with. For those with PCOS, everyone automatically will meet with them, because again, at the core of managing PCOS is really a big focus on nutrition and exercise. Okay. Final question, is it possible to plan twins with IVF? Is it recommended given the increased risks? So another good question. The answer is, our goal is always not only having a healthy baby, but one healthy baby at a time. So we don't intentionally try for twins because twins do represent a higher risk pregnancy, both for mom and for the babies. Does it happen? Yes, it is actually a higher risk of happening with ovulation induction because there are, up to about 4 eggs potentially that are available that cycle, and we can't control exactly how many fertilize and implant. Most eggs don't fertilize and implant. That's why we feel comfortable up to that number of eggs. So twin with the use of Clomid, which is one of the ovulation induction medications, can happen up to about 8 to 10% of the time. We often, though, use a medication called letrozole. That's actually the preferred medication for those with PCOS. The risk of twins is lower with that. With IVF, we typically transfer one embryo at a time. There are some exceptions to that. For example, if a woman is 38 or older and not doing the genetic testing of the embryo, then we would put back 2, not because we're hoping for twins in that case, but because the efficiency declines with age. So we're putting back 2, hoping that one of them is a good one. Okay, perfect. So thank you all for joining me. I hope that this was useful. Again, feel free to reach out, and we're happy to have a one-on-one discussion and help you on your journey. Thanks, everyone. Have a great night.